Hi, this is Alicia Bright again. We're talking about respiratory medications. This is supplementing our lectures on gas exchange. So the medications that we're going to talk about pertain to all people with respiratory conditions, lower respiratory conditions. But specifically, we've been talking about asthma, COPD, emphysema, and chronic bronchitis, emphysema and chronic bronchitis being subsumed under the idea of COPD. So reviewing bronchial asthma, recurrent and reversible shortness of breath. So we know that asthma generally comes and goes. Sometimes people grow out of it, sometimes it stops, but sometimes it continues and can develop into COPD. So obviously this is caused by bronchospasms, inflammation of the bronchial mucosa, edema of the bronchial mucosa, and production of viscid mucus. So the air is having difficulty going in and out through the bronchioles, so it gets trapped in the alveoli. And this can ultimately result in alveolar remodeling, which is what we see with COPD. But sometimes, as asthma is really well managed, then that doesn't happen. And like I said, sometimes people just grow out of it. So the alveoli remain open in this situation, but the airflow to them is obstructed. And so we see the classic wheezing and difficulty breathing with asthma attacks. Chronic bronchitis is a chronic continuous inflammation of the bronchi and bronchioles as a result of exposure to bronchial irritants, such as cigarette smoke or a lot of dust or pollutants in the air. Emphysema refers to what happens to the alveoli as a result of air trapping and thinning of the alveolar wall. The air surface, remember, is decreased because the alveoli start sort of blebbing together. The walls fail in between the two alveoli. You can see on the left the healthy alveolus, and on the right you can see that they're damaged and there are fewer air sacs. They're sort of joined together, which means there's less surface area, less alveolar wall space for gas exchange to happen across. And the effect is that ventilation is impaired. So there's generally 4 categories of drugs that we're going to talk about in this lecture. Bronchodilators, including the beta-adrenergic agonists and xanthine derivatives, the anticholinergics, the corticosteroids, and leukotriene receptor antagonists. This is the newest class. So we've got, generally speaking, 2 types of drugs. We've got the long-term drugs that we put people on to prevent asthma attacks, and then we've got quick relief drugs that help us open up those airways when somebody does start having problems. The long-term control is, for instance, the leukotriene receptor antagonists that we were just mentioning about, the newest class of drugs. People might take inhaled steroids, and they may be on long-acting beta-2 agonists. We're going to talk about alpha beta-2 and beta-1 in a moment. And then there's the quick relief drugs, such as IV systemic corticosteroids or even PO corticosteroids, and short-acting inhaled beta-2 agonists. I have this chart in here because it sort of gives you an idea of what's happening with the allergens, dust, wool blankets. Sometimes people are allergic to feather pillows and so forth that go into the airways and trigger histamine releases. So this is part of the process with the white blood cells. Histamine causes vasocongestion, which causes swelling in the airways. This is the same kind of thing that causes hives. If you've ever broken out in hives, those big red welts that are itchy. Or when you have sinus congestion related to seasonal allergies, if you have hay fever, same kind of histamine stuff goes on in your lungs. So across the bottom, they describe what different drugs do. Leukotriene antagonists block the release of leukotrienes in the lungs. So this keeps the bronchial release of histamines from happening at all. This stabilizes the substances, the white blood cells that would cause this allergic reaction. Theophylline is another drug we're going to talk about. Increases cyclic AMP. It inhibits breakdown of sensitized mast cells. So again, it stops the mast cells from releasing the histamine, serotonin, and CRSA that cause the vasocongestion and the bronchial swelling. Mast cell stabilizers also help inhibit that histamine release. Sympathetic agonists stimulate. Remember, an agonist is something that supports it, as opposed to an antagonist, which blocks it. So the sympathetic nervous system, this would be a sympathetic agonist, which stimulates the sympathetic system to decrease mucus secretions and relax bronchial muscle spasms. So think about your sympathetic nervous system. Yeah, it's the fight or flight system. It helps your body open up the lungs, increase the heart rate, get the blood pumping, and vasoconstricts the periphery in preparation for running away from danger or turning around and fighting it. That's sympathetic nervous system stuff. And then there's corticosteroids, and these are the heavy hitter anti-inflammatory drugs. And we'll talk about those. They can be topical or systemic, and they reduce mucus secretions and, again, tissue histamine. Bronchodilators. So these are beta agonists. These are things that support the beta effects in the body. They're a large group of sympathomimetics. So sympathetic nervous system, and mimetics, meaning they mimic the sympathetic nervous system. So you can expect that these things are going to rev you up. We use these only during the acute phase of an asthma attack because they quickly reduce airway constriction and restore normal blood flow by stimulating the beta adrenergic receptors throughout the lungs. So brief review here, you might have remembered from pharmacology, alpha 1 and alpha 2 are differentiated by the location on the nerve, but the alpha causes vasoconstriction. Beta 1, on the other hand, is primarily located in the heart, and it causes cardiac stimulation. And it's really hard to get drugs that do the beta 2 thing without also getting some beta 1 effects. So the beta 2 effects takes place in the smooth muscle of the bronchioles, arterioles, and visceral organs, and it causes relaxation of the bronchial and the GI. So this is what we want here is the bronchial relaxation, so that the bronchioles open up and let the air in and out. So if you think about it, these side effects are going to make sense. And when you're studying pharmacology, a lot of times the side effects are logical extensions of what the drug is supposed to do. So the drug is supposed to open up, it stimulates the sympathetic nervous system. So yeah, if you have a lot of adrenaline, think about what that's going to do to you. It's going to give you a headache. You may have some insomnia. You may just be really restless, anxious, tachycardia, fast heart rate, hypertension. You may have some nausea and vomiting. The beta agonist, the mechanism of action happens at the specific receptor. So these nerve receptors that get stimulated to have a sympathetic response. And it ends with the dilation of the airway. So the activation of beta 2 receptors activates cyclic adenosine monophosphate, CAMP, which relaxes the smooth muscles of the airway, results in bronchial dilation and increased airflow. Yay, team, that's what we want. Anticholinergics include Atrovent, Spiriva. They have a slow, prolonged action. So these are used to prevent bronchoconstriction. This Atrovent is not an emergency drug. It's a prevention drug. And so we'll use it not when somebody is having a crisis, but in order to prevent a crisis. Okay, xanthine derivatives are another kind of bronchodilator. Theophylline is the one that we use. Aminophylline is a synthetic one. These were based on plant alkaloids. They're based on theobromine and theophylline, which are the active ingredients in tea that gives your cup of tea. There used to be advertisements for Lipton, the brisk tea, and brisk tea has a lot of caffeine in it. So if you think about any time that you've ever had too much caffeine, you probably got a little jittery, a little wired, a little tense, muscular tension. All of that, those are side effects of xanthine derivatives. However, what they do is they dilate the airways, and that's why we use it. We use it for mild to moderate cases of acute asthma. We don't want to use it long term. There are we might use it long-term in COPD, but it's not used as often because there's a lot of drug interactions. But they do cause bronchodilation by relaxing smooth muscles in the airway. They relieve bronchospasm, getting in and air in and out of the lungs. But again, they cause CNS stimulation, cardiovascular stimulation, increased force of contraction, and increased heart rate. Right? Getting the heart pumping and getting the body ready for that fight or flight response. It also, though, increases blood flow to the kidneys. So you have that diuretic effect, which is why coffee shops have got to have restrooms because, the stuff goes right through you. So side effects, nausea, vomiting, anorexia. It might cause some gastroesophageal reflux. So people who are having a lot of reflux when they're trying to sleep at night might cut down on their caffeine. But if they're having that problem, we might need to adjust their medications. Side effects like sinus tachycardia, which is a regular but fast heart rate. Maybe some PVCs, extrasystole, some odd beats in there, PACs and PVCs. It's premature ventricular contractions or premature atrial contractions. People might have palpitations. That's the experience of having their heart beating kind of funny. And they could have ventricular dysrhythmias like premature ventricular contractions. And like we said, increased urination. Okay, corticosteroids. So we're going to start on corticosteroids here. We're going to do a lot more with this when we get to inflammation next week or the week after. Corticosteroids are a really powerful anti-inflammatory class of medications. In terms of respiratory, we use it for chronic asthma. This is not a rescue drug. This is something that people take in order to prevent asthma attacks. They can take oral form or inhaled forms. If they use it in inhaled form, it has fewer systemic effects. And we're going to talk about those systemic effects when we get to Cushing's, because Cushing's is sort of the poster child for the side effects of corticosteroids. But the advantage of taking an inhaled form is that you don't get so many of those side effects. You get very few because it's a topical administration. What you're doing is inhaling those steroids right into the area that needs it. It's like instead of taking systemic steroids, if you have a little eczema on your leg, you put a little steroid cream right on that little spot of eczema, and that's all it takes. And you don't have the side effects that you would if you'd taken it by mouth. So once people are put on steroids, it may take several weeks for the full effects to be seen. What they do is they stabilize the membrane of the leukocytes that release these bronchoconstricting substances like histamines. They increase the responsiveness of bronchial smooth muscle to beta adrenergic stimulation. Medications that are considered inhaled corticosteroids include Beclovent, Vanseril, Asmacort, decadron phosphate or dexamethasone sodium phosphate or Respihaler. There's fluticasone, which is Flovent or Flonase. By the way, Flonase is also used to decrease sinus reactions to spring fever, haha, we've got that. To hay fever, for instance, seasonal allergies. Topically, there aren't a lot of side effects. There are some, however. You might get a little bit of irritation in the pharynx, causes coughing. You might have a little bit of a dry mouth. Most meds that are inhaled, the inhalers, are pretty benign. You don't have to worry about them bothering the mouth, but if you're taking corticosteroid inhaler, after you take it, you should teach the patient to wash their mouth out really well. If we have corticosteroids sitting around in the mouth, they can suppress the normal white blood cell function that keeps us from developing fungal infections such as thrush. You may see babies or older people developing thrush, and part of that has to do with the immune system in the mouth. So if somebody's on corticosteroids, they need to rinse their mouth really well before swallowing that, or after they inhale the medication, they have to rinse their mouth. The last class of drugs are the leukotriene receptor antagonists. These are a newer class of asthma medications. Singulair, you may have seen these advertised on TV. Montelukast or Singulair is probably the most popular. Accolade is another one, and Zyflo is a third. These leukotrienes are released when triggers, things that trigger asthma attacks, for instance, cat hair or dust. These triggers start a series of chemical reactions in the body. These leukotrienes are the parts of the system that causes the inflammation, bronchoconstriction, and mucus production, and result in coughing, wheezing, and shortness of breath. So what these leukotriene LRTAs, the antagonists, leukotriene antagonists, they block that leukotrienes from doing what they're supposed to do. They block them from attaching to receptors in the cells in the lungs and the circulation. So since the inflammation is blocked, the asthma doesn't come to begin with. They don't have the problem. It prevents asthma attack. Again, this is not a quick relief thing. This is not something to take when you're having an asthma attack. This is something that people take on a regular basis to prevent allergic-oriented asthma attacks. They're not without headaches. Montelukast has fewer adverse effects than the other two do. But headache, dyspepsia, nausea, dizziness, insomnia, and liver dysfunction are side effects of both of these medications. I hope that's been helpful. It's a little bit of an introduction to respiratory meds, and I hope this helps you understand nursing care for gas exchange.